So, good morning, everybody. I'm very pleased to be with you today, even if it's just virtually, and hopefully next year I will be able to join you and to interact with you. And I want first to thank Michelle Chadwick, who invited me to give 2 talks on idiopathic hypersomnia. So my name is Professor Yves Dauvilliers. I'm running the reference National Center for Narcolepsy and Rare Hypersomnia in France and in Montpellier, south of France. And I'm also a member of INSERM unit, which is a university and research unit to understand better this pathology. So I do have some conflict of interest with some big pharma interest in the sleep domain. So the first point I want to start with, because I have 2 talks, and I will start with what is idiopathic hypersomnia. So first, I want to come back to the complaint. There's 2 complaints under the umbrella of hypersomnolence. The first is excessive daytime sleepiness. This is very known, with inability to stay awake during the wake time, and with some different phenotype. Could be feeling of daytime sleepiness most of the day, or real naps, planned or not planned, sleep attacks, sorry, an automatic behavior with attention problem. So this is the main complaint with different, again, phenotype. How to assess that? First is the good clinical interview. You need to spend time with the patient to understand and to details this complaint. You can be helped by questionnaire with the Epworth Sleepiness Scale and other, depending on the pathology. You can use the agenda, the actigraphy, and to record sleep with neurophysiological assessment, and we will discuss that a bit, MSLT, MWT, and so on. And several etiology may explain for sure excessive daytime sleepiness, from very frequent condition, sleep deprived, CNS drugs, OSAS, and rare disease, IH and narcolepsy. The second symptoms I want to deal with under the umbrella of hypersomnolence is hypersomnia, completely different than excessive daytime sleepiness, and there is often a mix-up between both symptoms. And this hypersomnia is defined by an increased need for sleep. Could be at night with long sleeper, during the day with long naps, and day and night that may be above 11 hours. And this is often associated with sleep inertia. And again, good clinical interview to assess this hypersomnia during the weekday, during the weekend. You can use some questionnaire, agenda, actigraphy, PVT, and we will spend time on long EEG recording. And to explain these symptoms, you can have also different etiology, long sleeper, depression, drugs, and IH. And for sure, patient may have both problem, excessive daytime sleepiness and hypersomnia, but it is a separate topic, separate symptoms. So how to assess that correctly? You need a good clinical interview. First is to look for excessive sleepiness, as we discussed, and to quantify number of days per week, number of episodes per day, to not be sleep deprived for at least 3 months, and you go to 4.5 of the general population. This has been done in adult subject in US in most of 15,000 subjects by telephone survey. Regarding the naps, if it's 3 per week, at least 2 per day without being sleep deprived for at least 3 months is 0.7. And if we want to go to the long sleep at night, is 9 hours with unrefreshing sleep in the morning, to not be refreshed with bad sleep at night, even if it's long enough, more than 9 hours, is 1%. So I think the first step, as all clinicians, we need to have good clinical interview. And you can be helped by questionnaire, but this is just the second step. The questionnaire cannot really propose a diagnosis of presence of not of symptoms, and we use a lot worldwide the Epworth Sleepiness Scale. And if we assess with some cutoff, the cutoff is mainly above 11 is 17% of the general population, this is but in France, and 2% have above 16, so severe subject. So it's very frequent condition. But again, it cannot replace a good clinical interview because it did not differentiate fatigue and daytime sleepiness, and it did not assess the long sleep at night. So it's not enough. It's just to help and to quantify the severity of excessive daytime sleepiness subjectively. Now, how to quantify objectively this daytime sleepiness? There is two tools very known. The first is the MSLT. The patient is lying down in a bed with 5 times with 2 hours in between, and you quantify the propensity to fall asleep. And as you can see here, after the polysomnography during the night, you propose this MSLT with the 5 naps, and you quantify the sleep propensity, the sleep latency, and if the patient fall asleep in REM sleep or not. And this is very helpful for patients with narcolepsy. They are very sleepy, below 8 minutes, and they fall asleep in REM because of the dream content. And there is another test, the MWT, maintenance of wakefulness, that the patient is sit with 4 tests or 40 minutes, and the objective is opposite as the first, is to resist. And mostly is the objective to be sure that the drug is effective and the patient can drive. But now, how to assess the long sleep, the second part, the long sleep, the hypersomnia. There's 2 major questions in the sleep domain, very easy question, but hard to answer. How much sleep do we need? And how much do we really sleep? It's easy question, but it's not clear the answer because it's very variable between subjects. Most of subjects sleep between 7 and 8 hours when they are not sleep deprived. But there are some extreme normal variant, and short sleeper may be below 6 hours, is roughly till 20% of general population, but mostly they are sleep deprived. They claim they are short sleeper, but mostly they are sleep deprived with a higher number of sleep during the weekend and during the vacation. For long sleepers, depending on the definition, is above 9 or 10 hours, is 2 to 8% of the general population as well. Some patient or subject, I may say, some subject do not complain on daytime functioning where they are able to sleep as long as they wish or they need. This is the long sleeper per se. But some other subject complain of excessive quantity of sleep associated with abnormal daytime functioning that cannot resolve by increasing sleep duration. So this is what we will discuss. It could be IH. But also other subjects claim they are long sleeper, but they are mostly clinophile. They are in the bed, but they overestimated their sleep duration. They correlated that with the time in bed. So it's very heterogeneous, and to try to solve that, we need to separate what is face-to-face clinical interview, if it's phone interview, internet questionnaire, what about the wording of the questionnaire, if it's on the weekend, on the weekdays, if it's time in bed or really sleep duration, or do we need to go to actigraphy or polysomnography? Heterogeneity came also from the age, the gender, the context of medical associated condition. And we need to be sure that the question asked about nighttime, but also the 24 hours, so night and day. And this is not often done in routine. So if we go in this direction, we did the same survey of 19,000 subjects with my colleagues Maurice O'Ion in Stanford. This has been done in all US, and as you can see here, 8% of the general population complain about the prolonged sleep duration above 9 hours. And if you associated that with distress, impairment of daytime functioning is 1.6. So it's not an orphan disease, it's 1% of general population. And of interest, in the right part of the figure, you can see that the patient who is sleep deprived below 6 hours of sleep at night are at least the same problem during the day as subject who sleep more than 9 hours. So the impairment of daytime functioning in quality of life is very severe. In sleep deprived, this is very known, but also in long sleeper. So it's very variable, as you can see here, about the duration of sleep reported by the subject. But this is the report, the self-report. So we need to be sure and to quantify this long sleep problem. So what do we do in my lab, and I will come back to this protocol in a minute, but first we do the PSG and MSLT, as I briefly reported previously, to be sure that the patient is not affected with narcolepsy, there's no OSAS, no other condition that may explain the problem. But if you are convinced that IH could be one of the problem of the patient, we do a second assessment, PhD, and we modify the MSLT to awake the patient after 1 minute of sleep during the day to avoid the problem of sleep homeostasis. And if the patient fall asleep and have sleep duration about 10 or 20 minutes 5 times a day, that will disturb the second night after. So we modify the MSLT. We just quantify this propensity to fall asleep. And after of interest, we put the patient in a bed 1 night, 1 day, 1 night. I will come back on that in a minute. But here, globally, you can see a normal subject that wake up at 9 a.m. because he has nothing to do, because he is was in the hospital and he have a nap. And after a second night, a little bit less long, because probably of the nap of 2 hours performed in the middle of the day. So 1 night, 1 day, 1 night is 15 hours. And an IH subject fall asleep till, as here you can see, at 1 p.m. with a long sleep with a lot of cycle, and after a long nap with 2 cycles, and after you go back to sleep around 8 p.m. and after you have a long second night. And this patient sleep within this protocol 26 hours. So it's long. And this is one way, the best way probably, I do believe, to separate what is long sleeper, what is IH, what is not. So now we can discuss what is IH. It's a rare disease, unclear prevalence, because depending on the definition and the tools you want to use to be sure of the diagnosis. Estimated prevalence is 20 to 50 cases per millions. The onset is between 10 to 30 years old, but the delay of diagnosis is long. And we do diagnose patients after 20 years old till 35 years old, even older. Often familial cases, but not very well defined, not good studies on that. Unfortunately, because it's just clinical interview, the relatives are rarely recorded in the sleep center. Higher prevalence of female, we do not know why, but this is key, this is clear. And some patients may report spontaneous remission. It's not always chronic disease. What about the definition right now? The International Classification of Sleep Disorder, the ICSD-3, this is the criteria. So A is daily period of irresistible need to sleep or daytime lapses into sleep present for at least 3 months. This is the only question on sleep complaint. So nothing to do with sleep inertia, nothing to do with hypersomnia. So this is really a problem. Less than 2 SORM on the MSLT, no cataplexy, MSLT below 8 minutes, or long sleep duration, about 20 hours of recording, and 11 hours. So mostly 10 during the night and 1 hour during the day. But they accept the wrist actigraphy over 7 days. But for me, it's not enough. I will come back on that. You need to exclude sleep deprived and other conditions that may explain this, the complaint. So I have some concern about this definition. Item E4 is the same for narcolepsy. And again, there is no hypersomnia, no sleep inertia in. Number of SOREMs is very variable between tests. So it cannot be a key parameters here. Actigraphy did not measure sleep, it did measure rest. And which etiology you need to rule out? Sleep restriction, AHI, PLMS, but what about the value? Depressive symptoms, is it the consequences of the cause? Obesity, drug intake, so, and low sleep efficiency, do you recommend to have very good sleep at night or not? And this is not in the definition. So it's not very well defined so far. So how to best diagnose IH? We need to come back first to the clinical symptoms: excessive need for sleep, sleep inertia, to quantify the symptoms. And I will discuss a scale we developed recently. You need to look for the age and gender effect. The MSLT, you need to start with that probably. But again, it cannot exclude IH. It excludes narcolepsy spectrum. But if there is some complaint and you do believe it could be IH, it cannot be only diagnosed with MSLT. You need to go to a long sleep recording. But unfortunately, so far is not well standardized between lab and problem of cutoff, related age. So we need to do more. So we did propose, and I think it's nice, a questionnaire published 2 years ago in neurology. It's a self-reported questionnaire, 14 items to quantify from 0 to 50 the different symptoms related to IH. So 2 questions on nighttime sleep duration, because I discussed that this is just 2 examples about the ideal duration of nighttime sleep, above 11 hours, above 9 hours, and also the circumstances require that you get enough sleep or not, you know, on your daily life. Do you have enough sleep? And you can quantify that. There is some question for sure about sleep inertia, about sleepiness during the day, and the consequences of having these symptoms on daily life, on driving, on work, on social issue. 5 items on the consequences of having hypersomnolence. So we did that with the patient association and my patient, and we compared the results to control and to untreated patient with narcolepsy. And we defined some cutoff that differentiate IH and controls with the cutoff of 22. Of key interest here is that with the management is not trial, is just my patient. If you compare untreated and treated subject, there's a huge decrease of this IHSS score. And if we were lucky to compare patient to themselves, dependent sample, it's striking as well, even with a low number of patients, with 5 units differences to compare untreated and treated subject. So it's reliable, valid, and allow to quantify these symptoms in daily life. And we did a second study on using this scale, just published a few weeks ago, to confirm just in IH, no narcoleptic patient, no control, the psychometric property, the responsiveness of IH to medication. And we defined severity score to be affected with mild IH, moderate, severe, and very severe. And we define component as well on daytime functioning, long sleep duration, sleep inertia, and napping. So these findings should stimulate the use of this scale in clinical settings and research studies. This is in MAPI. You know, it's a MAPI Trust is a website that take care about all scales in sleep, not in sleep, in the medical domain. So you can ask MAPI for that to use it. So the impact of IH on family and society is huge. Their inability to wake up, to maintain energy for course and responsibility to alone created sense of dependency. The responsibility require unscheduled waking can be extremely difficult just to take care about about relative and kids at night. Sleep inertia can affect also the routine to take care about yourself, but also your kids. And the risk of falling asleep at the wheel may make driving very risky. So there's a lot of consequences, not just on the patient himself, but the family and the society and the work. So as I told you, IH cannot be just diagnosed with MSLT, and there's 3 papers, first from Atlanta, second in my lab, and third in Stanford, to prove that MSLT is hugely variable, the latency and the number of SORMs if you do and redo, if you repeat the MSLT in IH subject. So it cannot be a good gold standard, and I insist on that because it's often the only test performed in most of lab in worldwide. Actigraphy, as is also in the criteria, is there's several papers on that, so it's well accepted and less expensive than PhD, but is often overestimated the sleep and underestimated the wakefulness. You need standardized setting, and it cannot be a gold standard because it did not measure sleep correctly. So you need to record the sleep duration for the diagnosis. So there are several protocols that has been proposed. I will go fast because there's 3-4 different protocols all over the world with different inclusion criteria. The lack of validation, sometimes they accept physical activity, sometimes the duration of the recording is 20 hours or 24 hours, sometimes it's in the lab, sometimes it's ambulatory, sometimes they invited to the patient to take naps, sometimes it's just free running protocol, and sometimes the MSLT is performed before and sometimes after the long sleep recording. So it's unfortunately too much variable. In Paris, they did the first one several years ago, comparing 75 subjects to control. Of interest here, I just want to stress on that patients with IH are more sleepy than control on the MSLT, 7 minutes compared to 15 minutes, as you can see here. But of interest, just 60% of cases had MSLT below 8 minutes. So the mean of that is 40% of subjects are above the threshold of 8 minutes, and even 30% above 10 minutes. So again, it cannot exclude IH diagnosis. And second, it's question the mean sleep duration of 11 hours, because the mean sleep duration in control was 522 minutes. So the cutoff related to the 95 interval confidence interval is 9.3 hours. So why 11 hours on the ICST-3? This is not very clear. My friend in Bologna's group performed the ambulatory 24 hours polysomnography and then the PhD on MSLT. But in this study, they exclude IH subject with long sleep time because they were able just to find 2 patients affected with that, and there is no control. So it's very hard to use this protocol to define cutoff and to assess IH with long sleep time. They have been excluded in a recent short paper from Japan. Of interest, just to go to the 3 examples here. They performed the 24 hours polysomnography and after the polysomnography and MSLT. And they include just 35 patients and no control. But just to look at 3 examples. The first example is very long sleep. Here is 1,100 minutes. You see there's a lot of sleep during the 24 hours, but the MSLT is 9 minutes and 0 SORM. So a very long sleep with not huge sleepiness. Second example is patient with normal sleep duration, less than 600 minutes. But the MSLT is 4.6 and 0 SORM, a very sleepy subject in NREM, no REM sleep. And the third example here is long sleep duration, 900 minutes, MSLT 4 minutes, and 3 SORM, so probably narcoleptic patient. So that confirms that is very heterogeneous under the umbrella of narcolepsy for the last one, but under the umbrella for the 2 first for IH, but it's completely different IH phenotype. And the MSLT cannot diagnose IH. The sensitivity here is just 12%, so it cannot be done to diagnose IH. So there's different assessment, different pathophysiology with 2 dimensions, as I started with high sleep propensity, so sleepiness, and prolonged sleep duration at night and during the day. So we need better diagnosis to standardize the procedure between the lab, the duration of the recording, to do the continuous recording before or after MSLT, and the influences of physical activity, about light, about internet, but so a lot of confounding factor. It's a rare disease, so we need a specific marker and specific cutoff for the test you want to use. And you need to exclude depression, clinophilia, OSAS, obesity, periodic leg movement. So this is not done. So what we did, and I already show you partially this slide, we did this protocol, very standardized, with this 32 hours, so it's longer than 24. We add a second night to be sure that it's not just long sleepers, because when you are long sleeper, if you sleep also during the day, you cannot sleep during the night. And we define cutoff of 19 hours. So this is published in Annals of Neurology as the best alternative criteria to diagnose IH in our hands. So we include more than 100 subjects, and we compare that to other patients with sleepiness, but not IH, and control. And we were able to define cutoff. It's 19 hours over the 32 hours control bed rest protocol. I have no time to go too much into the details, but if you go for this long sleep duration, they also have lower MSLT, so they are very severe, more sleep inertia, and a tendency to be overweight. It's a recent paper we just published in Sleep is Complex, but I like this way to assess the patient. We recruited 266 drug-free patients with hypersomnolence complaint, could be EDS or excessive quantity of sleep, and they performed the protocol just I mentioned to you, the PhD modified MSLT and the 32 hours bed rest condition. There are no sleep deprived, no cataplexy, no chief work, orexin is normal when it has been measured. And we separate patient with total sleep duration above and below the cutoff of 19 hours, and also based on the MSLT below and above the 8 minutes. So it's a complex table. I invite you to read the paper, but I sum up that you the main results. Patients above 19 hours are younger, with high sleep efficiency, high percentage of slow wave sleep, and MSLT below 8 minutes compared to patients below 19 hours for sure. And patients below 8 minutes on the MSLT have less complaint of long sleep duration, high sleep efficiency, and increased total sleep time. No interaction with BMI and BDI. BDI is the back depression inventory. In this paper, we were interested in proposing this algorithm. So the patient came because of a complaint. Could be isolated daytime sleepiness, isolated excessive quantity of sleep, or both. Mostly it's both, as you can see here on the number, 180 subjects. And after we separate as a function of objective measurement, no objective measurement on MSLT or long sleep duration, or just isolated objective daytime sleepiness, but normal sleep duration. In contrast, isolated hypersomnia, or both. They are objective EDS and objective hypersomnia. And we exclude for sure patient with cataplexy, shift works, depression. After we exclude patient with some SORM on the MSLT. And after, do we need to exclude patient with some depressive symptoms, obesity, AHI above 10, PLMS above 15? What about microarousal? What about sleep efficiency, percentage of NREM and REM? And this is to illustrate that there is key discrepancy between objective and self-report sleep duration and daytime sleepiness, and we were able to differentiate what is the etiology of isolated objective EDS, isolated hypersomnia, or both problem. And this is required in what I do believe to better understand the pathophysiology, the biology, and to define specific biomarker to diagnose patient at best and to do personalized medicine. So we did the same for sleep inertia, just recently published in Sleep. Sleep inertia, as you know, is a very frequent problem, but poorly defined. So we define sleep inertia and sleep drunkenness based on 3 questions on the ISSS about the frequency and the duration. And in this study, we performed the PVT at 7 p.m. after we record the sleep at night in the lab, and we did also another PVT at 7 a.m., 7:30 a.m., and 11 a.m. after the MSLT. We did that in 62 subjects with IH and 140 non-IH. And as you can see here, very briefly, I want to stress on that sleep inertia is very frequent in IH subject, 60% of cases, but exists as well in 40 subjects of non-IH. So we love to say that it's very specific to IH, but it's not, because that exists in insomnia subject, in other subject, even sometimes in narcoleptic subject. And this is based on the questionnaire. And based on the PVT, as you can see here, there's a huge increase in lapses, but we use also other metrics, but let's focus on lapses, 500 milliseconds. It's lapses, so the number of lapses increased at 7 a.m. and 7:30 a.m. compared to 7 p.m. as a function of sleep inertia complaint. So, and that decrease at 11 a.m. being almost the same as 7 p.m. So sleep inertia in the morning is assessed correctly by PVT. It's an objective measurement of interest to look for drug intake and to confirm that it is reliable. So it may be helpful to optimize management. So if I want to conclude right now about what is IH compared to differential diagnosis, there is narcolepsy type 1. I did not spend time on it, but it's very known with cataplexy, with this hallucination, sleep paralysis, disturbed nighttime sleep, with this MSLT, very typical. And in the other part is IH. I spent a lot of time on that with excessive daytime sleepiness, being completely different, is long sleep night compared to patient with narcolepsy having short sleep night, non-refreshing naps with the sleep inertia compared to narcolepsy, no dream content mostly, no sleep attacks, and planned naps, but long planned naps in IH, and with hypersomnia and sleep inertia. And this MSLT could be one way, but not the only way, and a long sleep duration. And in between, we do have this narcolepsy type 2, which is not very clear, and it may be, in between IH and narcolepsy. And we do believe that NT2 could be part of the narcolepsy spectrum, because some patients, 20% of them without cataplexy, may have orexin deficiency. And for IH, the form with normal sleep duration, but very sleepy during the day, because of variability of SORM, it could be close to NT2. So it should be a continuum and not really this NT1, NT2, and IH. So we wanted to reassess and rephrase this. And we did that with my colleagues in Europe, publishing Sleep Medicine Review, and to do another classification. Narcolepsy type 1 and type 2 should be a narcolepsy spectrum with different level of certainty related to HLA and orexin. IH should be IH, but focusing on long sleep duration. And in between, there is patient with idiopathic EDS, a severe complaint of EDS, but not IH and not narcolepsy. So I did my best to explain how to define IH with long sleep duration that should be objectively assessed with long sleep recording, so-called hypersomnia. And the idiopathic excessive daytime sleepiness is in between, when there is no IH and no narcolepsy, but a complaint of excessive daytime sleepiness. So the patient may have sleep latency below 8 minutes, but no SORM, or one SORM at max, but it cannot be based just on SORM. We want to focus on the complaint because of the variability of SORM, as I try to explain to you. But there is also different level of certainty about the probability or definite criteria, because the patient can have a complaint with MSLT between 8 and 12 minutes, but problem of attention, problem of that may be correctly assessed by the PVT of the sort. So it's one way to solve the issue and to find next better understanding of this disorder. So to conclude on the first talk, IH is a rare disease who you need a good clinical assessment of excessive daytime sleepiness, excessive quantity of sleep and sleep inertia. PHG MSLT cannot be enough. There's no good test retest in IH and NT2 in terms of the results. Waking up the patient for MSLT preclude to record long sleep duration, so it cannot be the good test, not the only one at least. You need a better assessment of long sleep recording. Actigraphy is not validated and poorly reliable. You need to go to 24 hours at minimum, and probably I do recommend the 32 hours protocol, because the 24 hours protocol may have problem about long sleeper and standard and norm, especially with the age. But the 32 hours is also an issue because it's less feasible and costly. So we need new device for sure, new EEG-based measurement, but in the next few years it should come available. So at the end, I want to have homogeneous rare IH population based on clinical and neurophysiological biomarker, and to individualize patient just with EDS or just with hypersomnia or with both. So many thanks for your attention.